This is the video lecture for the patho of obesity. So just some facts, just some things to think about obesity. I'm not going to make you memorize these things, but just to think about what an issue obesity is in America, and it's just becoming more and more prevalent. About 40% of adults at the time that your last edition of your book was published were obese. I think that number is higher now. There's a lot of disparities, so meaning that there is a variance based on where people live, ethnicity, and income. 1 in 10 children become obese as early as age 5 or even age 2, which is pretty staggering. And then the rates are highest down here in the South. There's also higher rates of obesity with people who are Black or Hispanic. And then there's also rates that are higher with people that have less education and lower income, so people with socioeconomic stressors. So it's more complicated than we used to think, but the basic idea of energy expenditure is that if we have obesity results when we have too much in, so too many calories in, and not enough energy expended through exercise. Recommendations for exercise are 150 to 300 minutes per week of moderate intensity exercise and strength training twice a week. Obesity is a complex combination, though, of genetics, environment, psychological factors, and hormones. So it's not quite as straightforward as we used to think. So the pathophysiology of obesity is complex. This is when the general definition is body weight is beyond physical requirements, and we also have an increase in accumulation of fat cells. So there's an increase in the number of adipocytes, and that happens typically in childhood and adolescence. The actual number is usually reached at that time. And then the size or hypertrophy of adipocytes. So we have a certain amount, but they can grow in size. And so there's large increases in lipid storage, and pre-adipocytes are triggered to become adipocytes once the storage of existing fat cells is exceeded. There is a hormonal component to obesity. So leptin, as you can see on this picture here, this is released by the adipocytes themselves, the adipose tissue. And that is a hormone that lets us know that we have had enough to eat, that we are satiated. So that tells the body to stop eating. And then ghrelin is released by the stomach, and that tells the brain that we are hungry. And then insulin is released by the pancreas, and that helps to regulate our glucose. So adipose and obesity, so there's an increase in fat mass, and then adipokines are substances that are produced that contribute to things like insulin resistance. So the body actually, the cells are actually starving because insulin is not working as it's supposed to allow glucose into the cells. The body is less responsive to insulin. Dyslipidemia and hypertension. And these adipokines, so kind of like cytokines, but released from the adipose cells, these can disrupt immune functions and predispose to certain cancers. So this just shows some of the effects of adipokines. And so appetite decreases leptin, and so we have increased fat mass, and we're going to have less of that leptin. And we're also going to have insulin sensitivity that is decreased. Environmental factors, we have greater access to food with poor nutritional quantity than ever before. We also have things like food deserts in areas maybe where there's more poverty, where there's really less access to nutritious foods, especially affordable nutritious foods. And so one thing also is we often underestimate how many calories we take in, and then we overestimate how much exercise we've done. And so we're underestimating how many calories we've had, and then we're not exercising enough. Psychosocial factors, people use food for many reasons. Sometimes food is a source of comfort. Sometimes we reward ourselves with a treat. Associations with food begin in childhood, and our sense of satiety can be altered, so we might not feel full when we normally would due to psychosocial factors. We can have mindless eating, especially if we're on electronics or watching TV and just kind of zoning out. And eating is social and often is associated with pleasure and fun. So some people eat more when they're social, and also, especially if there's alcohol involved, people might eat foods that are less healthy. So health risks, this kind of reminds me of the table that we saw for renal failure, where it's this systemic effect. So obviously I'm not going to make you memorize all of these, but we're going to go through some of the key ones on the next several slides about the different systems that are involved. And so you're going to see another one that's like this when we talk about hepatic failure. So obesity, renal insufficiency or renal failure, and hepatic insufficiency or hepatic failure. These are all things that can cause widespread effects throughout the body. Obesity is associated with increased mortality, especially if we have increased visceral fat. So visceral is like abdominal fat. And so if we have more fat around the midsection, then that has an increased risk. Obesity is also associated with a reduced quality of life, people not being able to maybe do things that they normally enjoy because of maybe decreased energy, comorbidities that happen. And the good news is that most conditions that are associated can improve or even be reversed with weight loss. So let's start with cardiovascular problems. There is an increased risk of heart attack and stroke, and then that android obesity or abdominal obesity, where the fat is in the central area in the stomach, carries a greater risk. There's an increased risk of having high LDLs, which is the bad cholesterol, having high triglycerides, which is associated with carbohydrate intake. Those are fatty acids. So increased carbohydrates get converted to triglycerides, and decreased HDLs, which is the good cholesterol. So we have too much of the bad types and less of the good cholesterol, and also increased risk of hypertension. Endocrine problems, the main one to think about with obesity is the greater risk of type 2 diabetes. So that's the one that happens typically with people who are older, but we are seeing more type 2 diabetes in children, but it's associated with insulin resistance. So excess weight makes endogenous insulin less effective, and so too much glucose is kept in the bloodstream and the body keeps making more insulin trying to compensate for it. And then the beta cells of the pancreas get overworked and worn out, and they can no longer keep the blood glucose in the normal range. And excess weight makes the treatment less effective. So we have hyperinsulinemia, insulin resistance, and glucose intolerance. And these all lead to type 2 diabetes. GI and liver problems. Obesity is associated with increased risk of GERD, gastroesophageal reflux disease. We'll talk about that next week, but that's basically where there's increased pressure and that causes stomach contents to go up into the esophagus. Gallstones. So gallbladder disease is associated with obesity, especially high fat intake. And then fatty liver, or the other word for it when it's not related to alcohol, is called non-alcoholic steatohepatitis or NASH. And this is where lipids are deposited in the liver and it can cause inflammation. And the other type of fatty liver is due to alcohol, but this is one that's directly related to obesity. And this can lead to cirrhosis, and weight loss can improve this. Respiratory and sleep problems. We've already talked about sleep apnea. Obesity is a risk factor for that. People with obesity can hypoventilate. Weight loss can improve lung function, and as we know, it can also help with sleep apnea. And one thing that kind of adds to the problem of obesity is if we don't sleep well and we have poor sleep quality, then that can actually increase our appetite when we're awake. Musculoskeletal problems, osteoarthritis, we'll talk about, let me think about it, week 10, our last week. And this is when there's wear and tear, there's stress on the weight-bearing joints like the knees and the hips. And the increased weight from obesity adds more stress on those joints. It also triggers inflammatory mediators. And the end result of osteoarthritis is the cartilage is worn down. And it actually, we lose that cartilage, it narrows the joint space, and it actually causes the bones eventually to kind of grind together. And then there's also an increased incidence of high uric acid levels in the blood and gout with obesity. Cancer, obesity is one of the most important preventable causes of cancer. There's increased rates of several different types of cancer, a few here listed: thyroid cancer, liver, kidney, colorectal, and gallbladder cancer, and then female cancers of the breast and endometrium, and these might be associated with excess estrogen. Psychosocial problems, there's a lot of stigma in our society when people are overweight or obese. This leads to people having low self-esteem. People can be socially isolated. They might be either excluded or just kind of withdrawn. Increased risk of depression. And there's also proof that there is discrimination everywhere from getting jobs, education opportunities, and in healthcare. This is something I'm really passionate about. Health disparities is when people have poorer levels of care based on factors such as race or things like obesity or mental illness. And so this is something that I am not saying is okay, but these are some examples in the media of shaming people with obesity. So this is something that is probably meant to try to decrease childhood obesity, but it's really just shaming. So fat kids become fat adults. Big bones didn't make me this way, big meals did. And so clearly the motive for it was probably to decrease this, but unfortunately it has a lot of stigma involved. So drug therapy for obesity should only be used in conjunction with things like calorie reduction, exercise, and behavior modification. So mechanisms of drugs can be to increase satiety. Semaglutide or Ozempic is all over the news. So that helps a person feel more full, and so they eat less. Other medicines like Orlistat or Ally decrease fat absorption, so fat is lost. It's not absorbed into the body, it's lost through the stool. It's not recommended for people to be placed on prescription amphetamines for weight loss. Short term, there is a medication called phentermine and naloxone, and that is a non-amphetamine stimulant that can help, but it's really meant to just get people started with losing weight and not long term. So this is a person who lost quite a bit of weight in a month using phentermine. So it is effective, but it should really only be to get things started and in conjunction with the things I listed at the top here. So pharmacologic therapy for obesity, we need to be looking at medical conditions that people have, so comorbidities and risks. We need to educate people that drugs will not cure obesity. There's actually some evidence that the yo-yo effect of weight loss and weight gain can actually be just as harmful or more harmful than being overweight. And so we need to have a plan that involves education, exercise, and possibly medications and behavior modification. People need to have sustained changes in their food intake and exercise to have sustained weight loss. And then we need to make sure that people are properly taking their medications and they're aware of side effects, and that we're not using these medications inappropriately. Because there is, especially with phentermine, there is a risk of dependence. So lastly, this is something that you probably have already heard about, but I wanted to touch on it. You'll hear about it more when you have cardiovascular illnesses next semester, but metabolic syndrome is kind of a cluster of symptoms, and people that have metabolic syndrome have an increased risk of cardiovascular disease, stroke, so heart attack, stroke, and diabetes. So if people have 3 out of 5 of these criteria, then they have metabolic syndrome. So criteria includes waist circumference. So here it shows 40 inches or larger for men, 35 inches or larger for women. elevated triglycerides, so greater than 150, or if they're on medication for high triglycerides. Increased blood pressure, where it is greater than 130 systolically or 85 diastolically, or if they're on medication to treat hypertension. And then fasting glucose greater than 100 milligrams per deciliter fasting, or if they're on medication to bring their glucose down. Or if they have decreased HDL cholesterol, which is the good cholesterol, and that is if it's less than 40 for men or less than 50 for women, or if they're on medication for cholesterol. So let's just say, for an example, a person has a female has a waist circumference of 38. That would meet that criteria. If she has triglycerides of 130, that would not meet that criteria. Blood pressure, if somebody had a blood pressure of 129 over 90, that would meet that because they have that diastolic above 85. And then fasting blood glucose, if it was 101 fasting, then that would meet that. And so a person with what I just talked about would meet that criteria for metabolic syndrome. And then also the last one that would be decreased. So if that woman had HDL of 45, then that would be below the 50 that women should have. I'm not going to make you memorize all of these criteria. I think it is good to know the waist circumference, and it's good to just know in general what these values are, but I'm not going to make you memorize the lab values. And this is just a patho map of obesity and metabolic syndrome. So if people have obesity, that makes them have increased insulin resistance, and so that makes them have impaired glucose tolerance, and so their blood glucose is elevated, and that can lead to type 2 diabetes, which is a risk factor for cardiovascular disease. There's also an increased risk of coagulation, so blood clotting, and decreased breakdown of fibrin, so increased risk of clotting, which leads to the risk of cardiovascular disease, and then hypertension, increased risk of cardiovascular disease, increased triglycerides, and decreased HDL, cardiovascular disease. So just looking at all these risks that come together. So that is the key information for the patho of obesity. Thank you.